Good afternoon, everyone. This is Macy Morin from the National Association of Regional Councils here in Washington, D.C., and I will be moderating today's webinar, Older Americans Act 101 and Introduction. And we're happy to co-host this with the National Association of Development Organizations and have a great speaker joining us today from the National Association of Area Agencies on Aging, also known as N4A. And with that, I will pass it along to Leslie Wallach, who's the Executive Director here at NARC, to say a few words of welcome.
Yes, good afternoon. Thank you so much for joining us this afternoon. As Macy said, I'm Leslie Wallach, Executive Director of the National Association of Regional Councils. We're delighted today to join with the National Association of Development Organizations, NADO, and the National Association for Area Agencies on Aging, N4A, to bring you today's webinar on renewal of the nation's Older American Act, ensuring that older Americans age with independence, dignity, and good health. The program supports vital community-based programs to support and protect our senior population. Regional organizations play a big role in providing these services, both as the designated area agency on aging and for their other work in coordinating human services in their region. We applaud these programs and efforts to leverage other regional programs and services to support these inclusive programs for seniors and all citizens. The OAA will expire on September 30th, 2019. N4A has been leading the effort in providing education on the Older Americans Act. We're thrilled today to have Autumn Campbell with us to talk about the legislation and ways you can help educate your elected officials on the value of the program and the need for Congress to act in a timely fashion to enact the bill and provide sufficient funds to make sure these programs are available to your citizens. Before turning this over to Autumn, the N4A Director of Public Policy and Advocacy, and we are proud to say a NARC alum, I want to welcome Joe McKinney, our co-host and NATO Executive Director. We're happy to partner with them on this and many other policy initiatives. So I thank you and welcome, Joe.
Thank you, Leslie, and I'll just be brief and echo a lot of what you said. First off, we're excited to partner with NARC on this webinar. Leslie and I try to work together to find as many common interests as we can to work together, and this is certainly an issue that impacts both of our memberships and certainly something that's very important to regional organizations across the country. We're very blessed, as Leslie said, to have Autumn Campbell with us, not only today, but really throughout the year to help provide guidance, to help partner, particularly on issues related to the Older Americans Act and the provision of aging services across the country. I'd say that we're fortunate because Autumn has a pretty unique understanding of regional development organizations, having worked at one point for NARC, knowing many of both of the organization's members and knowing the roles that you play on a daily basis in the provision of services. So we rely very heavily, and I know NARC does as well, on Autumn and N4A to rally us, to provide guidance and information, and we're just absolutely very fortunate to have the partnership with both NARC and N4A, not only today in this webinar, but again throughout the year. So with that, I will turn it over to Autumn. As Leslie mentioned, Autumn is the Senior Director of Public Policy and Advocacy for National Association of Area Agencies on Aging. So Autumn, I'll just turn it over to you.
Great, thank you, and thank you all for welcoming us here today. We very much appreciate, I will echo the thanks, our partnership with NARC and with NATO, and certainly understand the important role that regional organizations serve in administering these critical programs and services to older adults and caregivers in their homes and communities. So I will not spend any time introducing myself and just thank again Leslie and Joe for that kind introduction. I'm happy to be here today. But I do want to talk just a little bit about my organization, the National Association of Area Agencies on Aging. N4A represents the 622 local area agencies on aging and serves as a voice in Washington, D.C. for over 250 Title VI Native American aging programs. And while we certainly are an advocacy organization, and I have the privilege of administering our policy portfolio here in Washington, we also have a number of other resources through the association that I want to make sure that you're aware of in your own communities, and hopefully some of these resources that N4A administers can help you. So I'll just talk briefly about these before I really get started with our discussion today about the Older Americans Act and the Aging Network, and what some key takeaways are from both OAA and the network that it supports. So in addition to being an advocacy voice for the Aging Network in Washington, D.C., N4A administers several other programs, a couple of which may be of particular interest in your communities. So you should know about the National Aging and Disability Transportation Center. This is a resource center that we partner with Easter Seals and is funded by the FTA. And the goal of the center is to provide technical assistance, research, support, and most importantly, I think, disseminate best practices in providing transportation access to older adults and people with disabilities. We consistently hear that transportation is the #1 requested service, and NADTC has a long history of focusing on enabling and encouraging communities to expand those best practices. So certainly, please check that out if you think that would be helpful. We also administer the Engaged Resource Center, which aims at providing resources to local communities that can be localized and tailored at a community level to highlight opportunities for older adults to become engaged in their communities, either through volunteer or other service work. And this is our effort at aiming to address social isolation among the older adult population. The Aging and Disability Business Institute is focused on providing technical assistance and enhancing the capacity not only of area agencies on aging, but other community-based organizations across the country to increasingly partner with healthcare systems and payers, particularly in the Medicaid managed care space and the Medicare space, to ensure that as integrated healthcare between the acute care system and the social services system, as they become more integrated, that existing networks, including the Area Agency on Aging Network and other community-based organizations, are poised and ready to serve as a key partner in expanding the access to community-based services that enhance health. And then lastly, but certainly not least, the Elder Care Locator, which N4A administers, is the national call center that aims to connect hundreds of thousands of callers every year with services for older adults and caregivers in their local communities. So the Elder Care Locator also provides access to consumer-oriented resources for local entities and also for individuals to learn more about what might be available to them in their communities. So I would encourage, if you haven't checked it out already, certainly encourage you to look at the resources that are available via the Elder Care Locator. And remember that hotline number. So, you know, the kind of subtitle of this presentation was the what and the why you need to know about the Older Americans Act and the Aging Network, but I'm really going to start with the why. And as I hope everyone on this call is aware of, and I'm sure acutely aware of in many communities, we are certainly an aging nation, and that is the why the Older Americans Act is so important and becoming increasingly important as our population and as the demographic changes as the population ages. So by 2030, more than 70 million Americans will be 65 and older. Even more than that will be 60 and older, which is the age of eligibility for the Older Americans Act. And I think that especially in rural communities around the country, that demographic reality is already hitting close to home. So I think it's worthwhile to just take a quick look at the current state of affairs in terms of our aging nation. And we have, as of 2016, nearly half of all states had already hit that population mark of nearly 20% at age 65 or over. So that's half the story, but the other half certainly is the rate of growth in the population of older adults. And you can see that in the decade between 2006 and 2016, and just keep in mind, baby boomers started turning 65 in 2011. During that decade, 34 states had a rate of growth in the population of 65 or over that exceeded 25%. So we are in the middle of this population change, and while the Older Americans Act has a 50-plus year history, which I'll certainly talk about, the reason that it's so important now to understand and know about and be aware of the advocacy opportunities around the reauthorization of OAA is because it is the foundational piece of legislation that aims to enable older adults to age in their homes, in their communities. And why is it so important? It's because 90% of older adults say that they want to stay in their homes and communities as they age. And again, OAA is that foundational piece of legislation that has established the infrastructure to be able to make that happen for millions of people. So I'm going to turn now to the what we're talking about today, the Older Americans Act, which was first passed in 1965. This is a picture of the act signing from back then. I imagine it would look a lot different today, hopefully a lot more diverse, but the Older Americans Act has a long history, a 54-year now history in providing the infrastructure for people to access community-based services and supports to age with independence and dignity where they want to be in their homes and communities. Often people don't know or are surprised to learn that the Older Americans Act, when it was passed as part of the Great Society Initiative and alongside Medicare and Medicaid. The original intent of the act, while it certainly hasn't changed in its overall mission to enable people to age at home and in the community, it has changed in the way that mission has kept pace, so to speak, with the growth of Medicare and Medicaid. Older Americans Act is the only piece of legislation that was passed at that point that is discretionarily funded, so funded on an annual basis in Congress. As we all know, Medicare and Medicaid are on the mandatory side of the federal ledger, so the funding keeps pace with the growth in need and demand, or at least that's the intent of it. Certainly the Older Americans Act is much different, and that means that today the funding for the Older Americans Act is dwarfed by that of Medicare or Medicaid, even though the intent was to serve as kind of a third leg of a three-legged stool when it was first passed in 1965. In 1973, the reauthorization of the OAA created the Aging Network. So that's when area agencies on aging were first established, and that was, I'm sure that date and time sounds very familiar for many on this webinar. That was during the process of expanding regional governments and a regional focus on planning and development and coordinating. And certainly aging services were included in that, and area agencies were first established in that 1973 reauthorization to play that regional planning, developing, coordinating service delivery role. Today, the Older Americans Act certainly, again, remains the foundation of this network of home and community-based long-term services and supports, but it is not the entirety of the network by far. So area agencies on aging have their foundations in OAA, but they do many more things now, and I'll get into that in a little bit. And then the Older Americans Act is a bit unique in that it focuses on older adults 60 and over. So it is not anyone 60 and over is eligible to receive access to services. It is not an income-based program, but given the nature of funding, certainly those services are targeted toward the most frail, most in need, and the most vulnerable older adult populations. So before I dig into any details, I really think it's important to note, and especially for the folks on this webinar, given your leadership roles in the community, that the Older Americans Act is unique in that it establishes an obligation for advocacy for aging network stakeholders, for older adults and for caregivers. And this is something that you don't see in a lot of federal authorizations, but within the Act, at the federal, the state, and the local level, the area agency on aging level, stakeholders and participants have the onus to serve as advocates for those older individuals. And that can look like a lot of different things. It can be on a very individual level, in connecting someone with healthcare services, or on a much broader level in terms of making sure that policymakers and leaders know and are educated about the role of the Older Americans Act. So we often at N4A make sure to emphasize with our membership that they are federally charged with being advocates for older adults in their communities. Okay, so now I'll get into some of the high level but important details about the Older Americans Act. And I think it's important to start out with, well, first of all, OAA is relatively simple. It is an act that has 7 titles, and it is a kind of beautifully simple piece of legislation that is really focused on local control and flexibility, and is not, all things considered, all that directive in terms of the policies that are laid out in the act. But first and foremost, the intent of the act, as you can see, are things that I think everyone can get behind: providing access to adequate housing, adequate income, health, employment opportunities, dignity, and cultural participation, focusing on the most vulnerable older adults, making sure that there is a foundation for research and best practice dissemination, and also certainly independence, freedom, and protection from abuse. So I think in a very, very large picture way, the Older Americans Act maybe was the first piece of federal legislation to really establish what I think we now know and are referring to as the social determinants of health. So making sure that we're putting out there, these are the things that people need to thrive in their communities, and that is built right into the structure of the Older Americans Act. Similar to other pieces of legislation, the Older Americans Act often has a 5-year period of authorization. The current authorization was only 3 years, and that was due to some complications with the funding formula. Again, it is an act that has 7 titles, and I'll get into some of the key ones. In addition to establishing the objectives of the act, the second title establishes the federal body, the U.S. Administration on Aging, which is currently and several years ago was rolled into partnership with some of the federal initiatives around disability, and now the Administration on Aging exists under the umbrella of the Administration for Community Living, but still the Administration on Aging has authority over Older Americans Act programs and services. The Title III of the Older Americans Act is really where the bulk of the work gets done. That is the title that is most focused on providing direct services in communities to older adults and caregivers, and roughly 70%, a little over 70% of funding for the Older Americans Act is administered through Title III programs and services. So what do those Title III programs and services look like? Well, they're what we call Title III of the Older Americans Act is the core programs in Older Americans Act. And these exist in several different buckets. Title IIIB is the one title that is a flexible funding stream that area agencies on aging can use to identify and provide resources to over 25 different services that they're authorized to do in their communities. And this can look very different depending on the community. The needs of a rural community are often and obviously very different than maybe the needs of a more urban community. So Title IIIB really establishes the flexibility, although it is certainly not sexually named, but the flexibility for area agencies to really customize the services that they offer in their portfolio. Certainly chore services, home modification, adult day center, legal services are authorized under Title IIIB. Information and referral assistance, which I'll talk about in a minute, is authorized under there. And this is this title is really the glue that holds these core programs and services together. Other Title III services, which I will discuss as well, are particularly focused around specific service delivery mechanisms, but area agencies on aging work a lot of magic with Title IIIB funding. So N4A's objective in going into any authorization is to maintain local flexibility so that AAAs can direct these dollars where they're needed in the community. Information referral assistance is under Title IIIB is a key and critical role of area agencies on aging within the aging network. Often if AAAs are not directly delivering any other services, they are playing this role of information and referral assistance in their homes and communities. So this can be anything from running the local hotline to doing case management, exploring opportunities within care transitions out of hospitals to prevent readmission. I mean, you can see the list, and this is only a partial list of the services that that area agencies provide under 3B in terms of information and referral assistance. So the rest of Title III, and while I'm certainly not prioritizing by any stretch what is offered under those core services, I just think it's really important to know that 3B is a flexible, that flexible pot of funding. And the reason is because people, when you think of the Older Americans Act, often focus on solely the nutrition services. So when we're up on Capitol Hill and talking to members or staff and saying, you know, we're here to talk about the Older Americans Act, often the response that we get is, oh yeah, I know that. I know Meals on Wheels, which is absolutely a critical part of the OAA, but it is a part of the Older Americans Act. So within the Older Americans Act, Title IIIC is where those nutrition services are coordinated and delivered. And that includes the congregate meals, so the kind of senior center meal services, the home delivered meal services, and there actually is a commodity program that is funded through the USDA that is authorized under Title IIIC of the OAA as well. Title IIIE of the Older Americans Act is the National Family Caregiver Support Program, and that is the only federal program right now that is dedicated in any large way to providing resources for caregivers. So there's 5 different services under 3E that are authorized that AAA can provide to caregivers in their community, and this is a caregiver for anyone over age 60 or even older caregivers who are caring for either adult children or increasingly their grandchildren can receive access to Title IIIE services through this program. The most common services through Title IIIE are respite, support services, whether it's through counseling or other caregiver groups, and education and training, but there are 5 different ones that are authorized under that. Title IIIB of the Older Americans Act has, the funding for Title IIIB has certainly lagged behind many of the other titles, but this is where access to disease prevention and health promotion services happens. So if your area agency on aging is running a falls prevention program or a Tai Chi exercise program or a chronic disease self-management program, oftentimes that is funded at least in part through Title IIIB of the Older Americans Act. And as of 2016, all of the programs that are funded through 3D are required to be evidence-based. And given the limited funding of 3D, I know this has caused a bit of pain in especially smaller communities. So that's one of the reasons I'll talk about in a minute while we're really focused on expanding access to funding for other demonstration programs, because 3D programs at this point need to have that evidence-based, that proven method of effectiveness. So the Older Americans Act, in addition to Title III, also authorizes several other programs. Under Title V of the Older Americans Act, this is where the Senior Community Service Employment Program, or CSEP, or it might also hear it referred to as Older Worker Workforce Development, is authorized. And this is administered through actually the Department of Labor, the ETA, Employment Training Administration within the Department of Labor. As of 2016, roughly 60,000 participants receive services through Title V, CSEP. And essentially what this does is subsidize the cost of employment, and then those individuals who are receiving services through CSEP are often placed in employment positions that are community focused and with other community-based organizations. So theoretically Title V should serve as kind of a dual purpose, not only enhancing the workforce capacity of community-based organizations, including area agencies on aging and other service providers, but also then offering access to an older workforce, which is often most vulnerable of unemployment and discrimination. Title VI is where the Native American Aging Program is authorized, and this funds a network of over 250, and these are not formula funded, they're grant programs, but over 250 Native American aging programs with the mission of providing in Indian country to Indian elders some of the same services and supports that are offered in that Title III, the core Older Americans Act programs and services. While the The mission of Title VI is to emulate that structure of services and supports. Unfortunately, funding for Title VI is woefully inadequate, even though it has received kind of a steady rate of increases over the past 4 or 5 years. But Indian elders still remain the most underserved and the most vulnerable elder population in the country. And Title VII is where you find the program authorized under OAA that focuses on older adults in institutions. While the overall mission of the Older Americans Act is to keep people in their homes and communities for as long as possible, we certainly recognize that that is not the place where everyone can be, that at some point the level of care needs become just too much, and people at some point may need to go into institutional care. And so Title VII under the Older Americans Act authorizes that ombudsman program that operates within long-term care facilities. Again, funding for Title VII is woefully inadequate to meet the need. And as independent living facilities and other assisted living facilities are increasing that maybe don't offer the same level of care as an institutional facility, there's certainly a need to increase the capacity of the ombudsman program to serve older adults who may be in independent living facilities. So I won't go into all of these in great depth, recognizing time constraints, but I just want to look at generally the overall the timeline of the Older Americans Act reauthorization throughout the years. Again, this is a program that has a 54-year history of delivering services in homes and communities. And throughout that time, the Older Americans Act has been authorized over a dozen times. Some of the authorizations, as you can see here, are kind of big and bold and add big new programs or titles or missions to the Older Americans Act. That was certainly true in 2000 with the addition of the National Family Caregiver Support, certainly the addition of nutrition services in the 70s with both congregate and home delivered meals. We like to think that adding the AAA network to the Older Americans Act was a big, bold, visionary idea. But then we have, and I think more often than not, kind of a modest reauthorization process for the Older Americans Act, where the focus is really on maintaining security and stability of those programs and ensuring that particularly appropriators know that their authorizing colleagues endorse these programs and want them to be funded. So I have a gut sense at this point that if an authorization is to be achieved in 2019, that it will be rather modest. It was rather modest in 2016. But we certainly are hoping that Congress will find some big visionary, bold room to, at the very minimum, increase authorization levels for these key programs. Now, how does the Older Americans Act actually work? And this is where I'm going to pivot a little bit and talk about the aging network as a whole. I know that hopefully those of you on this webinar are certainly familiar with your AAA, and that likely exists within the COG or the regional council or the development authority at a regional level. But the AAAs look different everywhere. So again, the beauty of the act is that it's fairly simple. Federal funding flows through the Administration on Aging to 56 state units on aging, and state and territorial units on aging. That funding is allocated federally via a funding formula that's based on the population of adults 60 plus in that state. States then take that funding, leverage it with any state funding that they may have, and via a population-based funding formula that is determined within their state, also then allocate it out to area agencies on aging. Now, again, there's over 600 area agencies on aging, but those AAAs contract with a network of anywhere from 20 to 30,000 local service providers in their communities. And I think that's really important to understand, is that the role of the area agency is not necessarily to deliver those direct services, but to, and sometimes they do, but to more often than not, be the planning, developing, and coordinating body that then contracts out for direct service provision. That said, all AAAs, even though I'll get into the diversity of the network, all AAAs are charged with playing a key role in planning, developing, coordinating, and in delivering, especially on the INR side, information and referral assistance side, that range of long-term services and supports in their communities. Again, even though the network is pretty diverse, I think it's important to remember that all AAAs have a common cause in offering those core services under the Older Americans Act, and that's really those Title III services. So caregiver support, nutrition, the health and wellness, so disease prevention, and health promotion programs, the supportive services, and that green circle there is where you see the supportive services offered under 3B, and that's that flexible stream of funding to provide up to 25 different authorized services. And then elder rights, and elder rights is certainly provided under core funding through access to legal assistance, but then also includes those Title VII programs. That said, these are not all the services that AAAs offer. Roughly 85% of area agencies also administer their state health insurance assistance program that offers insurance counseling. A number of AAAs, the vast majority, also offer case management services, often through partnership with their Medicaid, home and community-based services, either waiver program or managed care program. And then a good chunk of AAAs also administer the Senior Medicare Patrol or fraud prevention efforts in their communities. So this, I think, is interesting. And I'll get into this a little bit, but later on in terms of how this really colored our reaction to what the administration was proposing in their recommendations for the authorization. Just a little over 60% of area agencies on aging are administered through a local government entity. So you can see that includes nearly 30% of area agencies are based within a council of government or regional planning and development area. So that is the key reason, in addition to, just recognizing the value in these services, but that 30% chunk is why N4A takes so seriously our partnership with NARC and NADO. 25% of AAAs are administered through a county government, and this is particularly prevalent in the Northeast United States for whatever reason that is, but Pennsylvania, New Jersey, Maryland, New York, for the most part, all have county-based AAAs. And then a small percentage of AAAs, and in terms of number, but not necessarily in terms of dollars, are administered through the city government. And you really find this where you've got really big cities in AAAs that are serving large urban populations. So Philadelphia, New York, LA, Chicago, those are the AAAs there are based in the city government. But that said, 40% of area agencies on aging are independent nonprofits. So they may be an independent nonprofit. They may partner or be part of their local United Way. But all AAAs share the common thread of being federally designated as that area agency on aging. And this just gets to a little bit of the variety of the network. Like I said, depending on how AAAs are administered, and often that's determined in partnership with state and local governments, you may have a state like New York that has as many as 59 area agencies on aging, whereas Wisconsin has only 3. So the network is vast and diverse, and what a AAA looks like really depends on what the area agencies in that state look like. Just some FYI, some good things to know. On average, an area agency on aging budget is about $10 million. And you can see that roughly 40% of that, again, on average, comes from the Older Americans Act. So while OAA is key and critical to, and again, foundational to area agencies on aging, it is not often the only source of funding. Sometimes it can be a lot more than 40%. For example, in smaller AAAs that have a much smaller budget, so Older Americans Act funding may be a much bigger part of that overall budget. Or if you have a larger AAA or a region where they operate the Medicaid HCBS waiver, that OAA funding may overall be a much smaller part of the budget. Again, just helpful to know, on average, an area agency on aging has about 44 full-time staff, and I think the key number there is the number of volunteers. Area agencies very much depend on their position within the community to be a focal point for service among community members, and often older adults who are serving as those volunteers. Despite the diversity of the network, all area agencies on aging are responsible for assessing the needs of the community, educating consumers about what services are available, doing that kind of outreach, serving as portals to those services, and ensuring that people, to the best of their ability, that the individuals have access to the services that they need, and that they are serving the largest number of individuals that they can with those services by maintaining fiscal stewardship. So I'll go through these next couple of slides pretty quickly, but this gets to the fact that, again, Older Americans Act is foundational in terms of establishing the aging network and maintaining the mission of what area agencies on aging and their service providers do today. But it is not limiting. AAAs are expanding their scope and their focus, and you can see here that you know, probably now a higher number than this, but nearly the entire network is implementing evidence-based programs in some capacity. Over 70% are focused on enhancing livable communities and focused on that goal within their communities. This number, I think, too, is probably much larger now than it was in 2017 when this survey data was put together. But a majority of area agencies are also involved in integrated care initiatives. And again, this is that attempt to make sure that they are partnering with and aligning with healthcare payers, providers, and systems to offer access to those social determinants of health, to those community-based services that have an impact on individuals' health and their outcomes and their costs. And then about half of area agencies at this point are involved in a care transitions program, which often now looks like partnership either with a local hospital system or other healthcare entity. And really the goal here is to prevent hospital readmissions, to ensure that when people are released from hospitals that they have access to the information they need, their caregivers have access to the support that they need, and often doing really focused on medication reconciliation to prevent and reduce those readmissions, which are so expensive. And I'm going to talk about these next couple of slides just to emphasize that I think that the Aging Network, and I'm not necessarily speaking for anyone but myself here, but I think our Area Agency on Aging Network has a bit of a branding problem. Often, area agencies aren't necessarily directly identified as an area agency on aging. So there may be, and this happens a lot, there may be a AAA that's operating in a community where it's not really aware that that AAA is in fact a AAA. So I think, again, it's just important to note that while these programs and services and entities may not be immediately identifiable as connected to the Older Americans Act and as having resources and support through the OAA, that they probably do. And same thing too, and I know this this is not only it's not limited to aging and health, but area agencies on aging may be operating federal programs such as the SHIP program, which is known by different names in different states. And a good example here is the Michigan Medicare and Medicaid Assistance Program, which in and of its own right is very well known, but that is actually the federal SHIP program. So the more that we can do as advocates to connect those dots and make sure that lawmakers and policy leaders know when you're talking about programs in your communities that they are tied back to the federal decisions that are made, particularly around funding, I think that's really important. Just a couple of other pieces of information about the other roles that area agencies are doing. A lot of them serve as their Aging and Disability Resource Center in the community as well. And you can see, again, the percentage of area agencies that are serving as that state health insurance assistance program. Partnership is certainly important, and hopefully that is apparent today, given that we are partnering with NARC and NADO on this webinar, and NARC and NADO are partnering with N4A. But on average, area agencies have about 11 informal and 5 formal partnerships, and you can see some of the most common partnerships, be they formal or informal, that area agencies have. I think a couple of these that are increasing in frequent or in concentration are partnerships, especially formal partnerships with public housing and public housing authorities, and we're seeing this as the issue of access to affordable housing is becoming especially acute among older populations, and that is both within rural communities where individual housing may not meet the needs of older adults in that community, but certainly in more urban and suburban communities as well, as housing prices just become more and more unaffordable. And so while the Older Americans Act federally is funded at about $2 billion, the estimate is that every $1 of federal funding leverages about $3 in state and local funding. So you can see that it is not a, and we would like to see much more than $2 billion going toward these programs. I mentioned that they were dwarfed by Medicare and Medicaid, but you can see that it is critical that that funding is leveraged at a state and a local level and even on a private level to meet the needs in individual communities. Just again, some good FYIs. The most common source of non-OAA funding that AAA's leverage certainly comes from the state, often their Medicaid offices. And we're seeing that those emerging sources are increasing really rapidly, especially on the healthcare payer side. There are increasing opportunities for the Aging Network, particularly to partner with Medicare Advantage organizations, and that is due to a federal policy change over the last couple of years that actually allows Medicare Advantage organizations to pay for supplemental services and support for beneficiaries that are chronically ill. And this can look, these services can include housing, home modification, nutrition services, which should all sound very familiar as services that the AAA network has a long history and expertise in providing. So this slide gets to more on that, the fact that area agencies on aging are increasingly becoming involved in other partnership opportunities and revenue generating opportunities with healthcare payers and providers. But again, OAA still serves as that foundational piece and that mission providing piece, and also a key funding source still for the AAA network. So in terms of reauthorization, and I'll just go through the next couple of slides pretty quickly because I do think that we are working on scheduling another webinar in the coming weeks that talks really about the policy proposals and advocacy opportunities within the Older Americans Act reauthorization. But every year that Older Americans Act reauthorization either is due up, that the act expires, or that it hasn't been authorized and remains unauthorized, N4A's primary policy priority is to make sure that that act is reauthorized. Last time around, that took about 5 years. We're hopeful that it doesn't take that long this time. But we will continue to beat the drum, the advocacy drum of OAA reauthorization until we get it achieved. We did go through internally within N4A a very intensive and robust process seeking membership feedback and participation. This was last summer. And that process really dictated our recommendations for this reauthorization. So the recommendations that N4A has put out for Older Americans Act reauthorization, which I think certainly align quite well with NARCs and hopefully with NADOs as well, but they are very member driven. They're board driven, from the N4A board, and they're also relatively modest in scope. Overall, N4A maintains that the Older Americans Act works well. The biggest barrier to access to these services is certainly funding at a federal level. So our goal for this reauthorization is to, number one, ensure that that local decision-making authority and the local flexibility to determine what's needed at the community level is maintained. And while that sounds a little bit more defensive than offensive, that's for a reason. We have seen a couple of threats to that particular, hopefully won't end up in a bill, but we have seen a couple of threats to that particular vision and mission of the act. We're also asking Congress to be bold and to consider increasing authorization levels, fully recognizing that that doesn't mean that those dollars will actually be appropriated, but to consider increasing authorization levels by double. Right now, the Older Americans Act funding is such that the capacity of the network based on funding has eroded about 23% over the past decade. So when you take into account the population growth in 60 plus, as well as the inflation rate, the funding that is federally allocated right now is about 23% less than what it was even in 2010. So we want authorizers to fix that and to include those increases in authorization levels, and then to be bold and big and double the act over 5 years. We're also looking to Congress to provide additional opportunities for innovation and research and demonstration, best practice dissemination within the Act. And this really gets to Title IV, which I didn't cover before, but which is the research and demonstration arm of the Act and has not been funded for, at this point now, about a decade as well. There's a bit of a theme there. So we are asking lawmakers to take a look at Title IV to make renewed investments, at least in authorization levels in Title IV activities, and to ensure that the Older Americans Act is preparing the network to meet the needs of a growing demographic and of a changing healthcare landscape. And then there are a couple of areas where we think there are opportunities to ease administrative barriers within the Act, and ultimately the goal there is to provide access to services for as many people as possible. So Title IIIC, the nutrition programs, is one of those areas that we think it's worthwhile looking at whether or not Title III funds are going where they need to go between the congregate and home delivered meals programs, and if not, you know, are there some fixes that we can implement while maintaining the integrity of both of those critical programs? And then we also are asking Congress to include in the Act a very simple recommendation that states develop some sort of policy on cost sharing, even if that policy is that states they don't allow their area agencies to cost share. Right now, cost sharing is allowed in the Act for some services, not all services. But if a state doesn't have a cost sharing policy, then often the AAA network within that state are kind of left wondering what they should or shouldn't do around that, and causes confusion. And N4A has also been leading the national coalition effort around developing recommendations. So I won't say too much here, but the Leadership Council of Aging Organizations, if you are interested, certainly you can check out the recommendations that LCAO, as it's called, put to Congress, and N4A's fingerprints are deep in those recommendations. But we also wanted to engage in a very collaborative, very transparent, and quite robust process in terms of coming up with a set of 50 recommendations from the Leadership Council of Aging Organizations, and we prioritize that to also identify the top 10 recommendations. Okay, so I've been talking quite a bit, but I know we still have a little bit of time, so I'm happy to take any questions at this point.
All right, thank you so much, Autumn. Really appreciate the great overview that you gave. I did have one question come in, so for folks who are interested in asking a question, please feel free to type up a question in the question box on the WebEx box there, or you can send me a chat to the organizer and submit your question that way. But with that, we'll start with a question that we received earlier. Can you please elaborate on the Senior Medicare Patrol?
Oh, sure. So I probably can't elaborate too much, quite frankly, but this is a program. The Senior Medicare Patrol is a program that is funded through what's called the Healthcare Fraud and Abuse Fund, I think, or HCFAC. And the goal of Senior Medicare Patrol is to develop a volunteer-based initiative toward identifying and remedying Medicare fraud, waste, and abuse. This has actually been an increasing priority of the Trump administration. And in terms of what area agencies on aging are doing around Senior Medicare Patrol, they're often the administering body, so they're running the volunteer efforts. But that said, I am not personally an expert in SMP and the activities of SMP, but I am more than happy if you want to, and I'll just use this opportunity to throw my contact information up there. I'm more than happy to put you in contact with some of our other national organization colleagues who could provide more information about that particular line item. It is not authorized through the Older Americans Act. It is just one of those other programs that area agencies often have a hand in running.
Great, thank you. And just a reminder to folks that are on the line, if you're interested in getting a copy of Autumn's slides, you can actually look at the handouts portion on the WebEx box, and I linked it there. That way you can download it directly, but either way, I'll send an email to you all tomorrow. It should come through the GoToWebinar email service, and it'll have a link not only to Autumn slides, but also to a recording of this webinar. That way you'll have it for reference, and you can also pass it along to folks you think would be interested in hearing it. With that, I don't see any more. Oh, I do see a few questions. Here we go. Okay. Let's see. Someone said, thank you for the presentation. I work with rural SSAs to coordinate regional transportation service. We have recently learned a couple hospitals are closing in our region. Do you know of any senior grants or resources to help transport them longer distances?
So I'm actually writing this down. I would be interested in connecting you with the NADTC. I don't think for the questioner that you are alone in that scenario. That's been I think an ongoing and increasing challenge in terms of rural hospitals. There also might be some potentially valuable resources, whether this relates directly to funding through the Trust for America's Health, which represents public health stakeholders across the country. But I would be more than happy to connect you to NADTC about that particular piece. I will just use this as an opportunity to highlight that access to transportation services is one of those areas where Medicare Advantage organizations, we hope at least, are increasingly offering them to Medicare Advantage beneficiaries, which may not help in a rural area given that the concentration of Medicare Advantage beneficiaries is often much lower. But just keep in mind that is a benefit that may be available to MA beneficiaries, especially for those who are kind of chronically ill or complex need beneficiaries. So that wasn't directly to that question, but I'm happy to follow up with Macy and get information to you about NADTC, and my colleagues who work on that program probably have a much better expertise on some of those options.
Great, thank you. Next question. If we had to pick 3 programs that we should advocate to ensure there is no erosion of funds, what would they be?
Thank you for this question. I can tell you that my answer may be different from some other national organizations, but from N4A's perspective, the 3B programs and services, so Older Americans Act, Title 3B, supportive services, are, while not necessarily consistently under threat, the kind of unsexy services to increase funding for. And that Title 3B funding, again, is where the ability of area agencies to fill in gaps, to meet very specific needs of their community, to provide that information, referral assistance, and outreach assistance in their communities, it comes from and is funded from. So 3B is incredibly important, and our hope is that we won't see erosion in 3B, and we could certainly use all the advocacy to increase funding for 3B. The other piece about 3B that I didn't mention earlier, but we'll take this time to, is when N4A did our membership survey last summer to identify what our priorities should be for reauthorization and learn how Older Americans Act programs and services really are working in the field, and where could we potentially see some opportunities for improvement. One of the questions that we asked was about wait lists and unmet need. And according to respondents, while again you often hear about wait lists for nutrition programs, by far Title 3B services were where they were seeing their longest wait lists on a community level. So that could be wait lists for access to in-home care. It could be wait lists to get into adult daycare. It could be wait lists for case management services or transportation. So that's really where that need was very acute. So that's the one that I would flag first. Also, I think that while all OA programs and services need more funding, and the funding is not adequate to meet the need or the growth, that need is particularly acute in Title VII for the long-term care ombudsman programs. That funding has been stagnant now for well over a decade. So If your area agency is either administering or working closely with the Title VII long-term care ombudsman program, sometimes they run at a state level, but if that is an area that you are working with and seeing that need in your community, I would encourage that. And then also the Title IIIe Family Caregiver Support Program. I think that when you consider the fact that the network of roughly 40 million unpaid caregivers in this country provide unpaid caregiving valued at over $480 billion annually, which is more than the entire Medicaid budget. The fact that we have really one federally funded line item to support family caregivers in an official way that's funded at about $180 million a year. Again, that need and that value is just dwarfed by the actual, or the funding is dwarfed by the need and the value. And quite frankly, at this point in time with the system that we have, family caregivers, that unpaid informal caregiving support truly is the backbone of our long-term services and support system. So anything we can do to boost that funding for Title IIIe is greatly needed.
Great, thank you. We have time for a couple more questions, I think. The next one, please explain how the states should develop cost-sharing policies.
Yeah, okay, so this is one of those areas where we identified that there was confusion among the AAA network. Didn't necessarily have a solution to offer in terms of the states, but wanted to, and I'll be very honest, very gently encourage Congress to consider adding in the obligation of the state to put into place a cost-sharing policy of some sort. And there are a number of states that have cost-sharing policies. There's several services within the Older Americans Act that you can't cost share for. So nutrition services, certainly being one of those. But especially in some areas where there may be the ability, more affluent areas where there may be the ability of people to pay for services, but the AAA network simply may not be able to provide them. If someone could pay for them, that might be a way of increasing the reach. And again, the objective of this is to offer access to services for as many people as possible. That cost sharing is never mandated. So at no point can a AAA say to an individual, you have to pay for these or you can't get them. But the option of, in some places, if you can pay for them, we'll still keep you on this list. But if you can pay, upfront, we can then provide them, and could cut down on waiting lists. So I know it's a bit of a roundabout answer to your question, but we're not at N4A saying that states should develop a certain cost sharing policy either way, but just that state's policy should be made known. Hopefully will be developed with stakeholder input, including from the area agency network in that state, but that it should be very well documented and well known so that area agencies have a platform to go from. And right now, that's where the confusion is, that some states just simply don't have a policy around cost sharing, and AAAs may be hesitant to really look at what those options might be in their communities.
All right, I think that's a good place to wrap things up. Thank you, Autumn, so much for all of your information and staying around for Q&A. And from us, thank you all on behalf of NARC and NADO for joining us. Just a few things to let you all know about that are coming up soon. We have, I think Autumn actually mentioned this earlier, we're planning a follow-up webinar on this, focusing on advocacy strategy, because the OAA reauthorization deadline is coming up really soon for September 30th. So the tentative date for now is September 11th to have our follow-up webinar on advocacy strategy, sort of what this would look like, and how you should be reaching out to your congressional members on the parts of OAA or OAA as a whole that you care about. And with that, we'll be producing some some publications we'll be working on with NADO and InfoRay, I'm sure, including some talking points that you'll be able to utilize in your outreach, and of course, just an overall advocacy strategy that you can utilize as well. We have a one-pager on the Older Americans Act on our NARC website under our policy tab, I believe, but I'm happy to send that out tomorrow in a follow-up email. And with that, yeah, thank you all so much for joining. Thanks to our partners at NADO and InfoRay for being with us today. And we will send out information as soon as we firm up the date and the time for September 11th for our follow-up webinar. So thank you all and hope you have a great afternoon.
Great, thank you.